All right, so the next thing we're going to talk about is A-flutter. So this is atrial flutter. Now, in this one, this is where, okay, one thing that immediately kind of jumps out at you is this kind of pattern of the P waves, okay? So obviously you may have memorized that it has this kind of sawtooth pattern. So kind of like the teeth of a saw. So if, let's say you have a saw and it has these kind of, these teeth like that. So that's where that whole sawtooth pattern thing comes from. Okay. I can hear you laughing about my drawing. But so obviously atrial flutter has this sawtooth pattern, but what is it? So yeah, it's more than just a sawtooth pattern. What causes that? Let's talk about it. We have a pacemaker, for instance, over here. Let's just say here. We have one primary pacemaker that decides it's going to fire. Now, and the reason we know that is, for instance, in AFib, what's happening is we have multiple pacemakers. Oh, you can't see that, right? So here's what I just did. I said that, for instance, in AFib, we have multiple pacemakers firing more often than not in the left atrium. However, in atrial flutter, the reason these waves all look the same is it's one pacemaker that's responsible for that. So for instance, here, it'd be like this one abnormal pacemaker that just keeps firing. That's why they all look the same. If it was multiple pacemakers firing, these would have to look different, okay? Now, the other thing that you notice, though, is there's usually some kind of pattern to it, and it can be any different arrangement. In this case, we have, let's see, 1, 2, 3, 4. We have 4 that are abnormal, and then one signal goes through. And then we see 1, 2, 3, 4 that are abnormal, and then one signal goes through. So this particular type or variant of A-flutter is a 4-to-1, but it could be a 3-to-1. It could be a 5-to-1. I mean, there's so many options here. Just know there's usually some kind of pattern. Okay. The same thing, just like with AFib, A-flutter in terms of the management may be the same. Now, what you may see, sometimes you can have atrial flutter with a tachycardic rate. Sometimes you'll have atrial flutter with a bradycardic rate. It depends on what else is going on with the patient. What I want you to know, though, is in the setting of a tachycardic rate that's causing impaired cardiac output, because remember, we know that cardiac output is heart rate times stroke volume, right? Well, as the heart rate continues to go up, stroke volume may come down in order to maintain cardiac output. So the reason we want to bring down this heart rate when it starts getting too fast is because the stroke volume keeps going down, 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 down. Eventually, there's no stroke volume. So we need to kind of bring everything in balance again so that we can still maintain cardiac output, so we can still maintain perfusion. Okay, so we may have to use beta blockers or calcium channel blockers for rate control there again with the atrial flutter. But let's talk about it. Why would we use a calcium channel blocker? We said about the beta blocker because the ventricle, for instance, is innervated by a beta 1 receptor, okay? Obviously, we have, for instance, a vagus nerve that helps on the parasympathetic side to bring things down. What's going to be the neurotransmitter on the parasympathetic side? That's going to be acetylcholine. What's going to be the neurotransmitter on the sympathetic side? That's going to be norepi. Oh, we talked about this yesterday. Where's norepi made, for instance? Give me 2 places.